One. Hey, how you doing? Good, good. Get through the day. Yeah, last few weeks have been really busy. So it's good though. Next week, you have to go to Elk City. Yeah. So that's over by New Mexico. No, never been, but it'll be good. How's your time? How's your week? Huh? We have they do mental healthcare or whatever they call it. So I'll put an assistant out there for him. Then, mhm. So then we do. Yeah, we do a lot. We have a couple
Oh, that's a surprise.
Uh-huh. You need to sign there?
Here.
Yep,
And the pointer is where?
right here, dear.
Okay. What date here?
Yes, please, 28th. And then this one.
Same thing?
Yep. And this just is automatically on, correct?
It's on. That's working. Ships. And if you don't mind, if I can get you to wear that.
Yeah, fine.
Because a lot of times the students from watching later, we record.
Okay.
It's off. Come and introduce you. They have
Yeah,
a mic
Dr.
here.
Graham.
Okay. They probably use that.
Let's put it in my pocket here.
Yeah, if it's off right now,
Okay, let's turn it on.
it's just when you're ready to talk, flip that switch over.
When you introduce them, you need to speak into that so we can maybe move it over or whatever needs to be done. Because if we don't speak into the microphones, the people doing. So we
Here.
well, we can now, but so everybody, we can do it together. We could probably start in, let's say, about 5 minutes. Yeah, because this is when a lot of them start coming in. Okie dokie.
Okay, so, okay, got it.
Got it? Thank you.
Rice and chicken. Oh, fish? That's good.
Yeah, in the bottom right corner, it's we're being televised. CNN of all
Okay.
channels. Or Tahlequah, maybe. I don't know where they are.
Okay. Well, it really is going someplace? I'll get
The
some
White
rights.
House.
The White, yeah, I have a little piece for Obama.
Yeah.
So this is being, oh, okay. Is the, no, it's all right. Is that being sent someplace?
Yes. There's a couple places off-site
Okay, all
that
right.
are going to watch you.
All right, good. Okay. Okay. I'll get, I'll bezel my belt. No, it's all right. It's all right. Oh, shut up.
Yes.
Domperidone. Domperidone. No, don't. I'll tell you about it. Domperidone.
We're going to go ahead and get started. My name's Jeff Graham. I am a second-year fellow here at this institution, and I'm here to introduce Dr. James before he gives a speech on gastroparesis. Dr. James is currently the clinical director of the Gastroenterology Fellowship here at OSU. And in 1968, or 63, sorry.
68 was a good year.
68 was a good year, but 63 was even better because that's when you graduated from Michigan State and got your life in order. Decided to move to KU eventually, but before then you went to you did your internship as well as residency here at OSU, and then went to KU to do a gastroenterology fellowship. You've been honored and recognized for your contributions to the GI world, have participated in over 150 clinical projects, for which you've been recognized by the Researcher of the Year from the Oklahoma chapter of National Foundation of Ileitis and Colitis. You currently served on the pharmacy and therapeutics community for Blue Cross and Blue Shield from 99 to 2010, which was quite a long duration. In 2005, you were recognized as Doctor of the Year at the 105th Annual Convention at the Oklahoma's Osteopathic Association. And you've been a pillar at this hospital for quite some time. And we all thank you for being here and taking the time out of your day to teach us something about gastroparesis. So without further ado, Dr. James.
My granddaughter, and I have several, told me that I always start presentation with a joke. And so this is one that probably Joe Wolf told me. He's told me so many that I've forgotten them. But so the story about a guy like Joe driving down the highway in Oklahoma, beautiful day, and speeding along. And suddenly he looks in the rearview mirror, sees a highway patrolman's light flashing in the back. And oh my gosh, his first reaction was he sped up. Well, that really angered the highway patrolman. He eventually overtook him and said, you knew you were speeding. Yes, sir. He says, what in the world would possess you in this beautiful day, beautiful highway in Oklahoma, to be speeding like you have been speeding? And he said, and I saw you trying to get away from me. He said, no, I really, he says, okay, what kind of explanation do you have? He said, well, it's a long story, officer. He said, no, I only got room for short stories. He says, why? He said, well, many years ago, my wife ran away with a highway patrolman. Oh, is that right? So he said, yeah, it's interesting. He said, and then when I saw your light flashing, I kind of panicked. And I thought, oh, my God, I'm sure he's bringing her back. All right. So some of them not too good. Jokes. We're going to talk about gastroparesis, and see if this is, I got this right, okay. Good. So I'm going to review just briefly. We're going to define gastroparesis with a little bit of anatomy and physiology review as we, whoa, okay. I turned it off. All right, so it must be this one. There we go. In this region, this is the cardia, fundus, body, antrum. Okay? So what happens when you get a contraction, you get motility. And this is a disorder of motility. And if you learn this disorder well, you get a major step toward being competent as a physician. This is the tough one. There are lots and lots of folks who have gastroparesis. Okay? So up here in this fundal area is some specialized cells called the cells of Cajal, C-A-J-A-H, J-A-L, Cajal. And these make up the pacemaker. Did it again. All right. make up the pacemaker, and the cells then cause about 3 to 4 contractions a minute. This is very important. This is what happens when, so something happens, not just to the cells of Cajal, but to the vagal response. So the vagus nerve comes down from CNS, comes down and branches into the stomach, the left and right branches, and to stimulate the stomach. So anything that could disrupt that arrangement could cause gastroparesis. Sometimes it's functional and sometimes organic. And you guys got to learn the difference between what is organic and what is functional, because it's very important, because you can have gastroparesis of both types. It's a huge, huge category of disorderment of the upper GI tract. So as the contractions then start here, the pacemaker move toward the antrum and through the pylorus, and then repeat itself about 3 cycles per minute. The coordinated efforts of the contractions and the physiological material, mainly acid, but sometimes bile, enzymes, then help move this thing together. And in a pretty reasonable time, the stomach empties itself. And we're going to talk about the definition is delayed gastric emptying is gastroparesis. Gastroparesis means sort of paralyzation of the activity of moving material out of the stomach into the small bowel. So I don't. I'm having trouble advancing this. Okay, that's the red. That turns it off. You can turn it for me? All right. So here we have OSU orange, and oh, good. Just a little bit brief. Remember, this is the decade of the state schools. All the great state schools in the United States have done well. Ohio State, Michigan State, and Oklahoma State. All won their bowl games, did very well. So we're honoring Oklahoma State, again, with our orange depiction here. So the definition is some disorderment that creates a delay in gastric emptying. The symptoms, so you got to remember. So NEV, BP, nausea, big problem. Chronic nausea they come into, frequent vomiting, early satiety. They try to eat, they get a message, can't eat anymore. They can only handle small meals. Bloating and belching often go together, and pain. So the big two, nausea and pain, drive you to see the doctor. And then often the patient is then treated for pain because that's all they had the discomfort, and they went up being on narcotics and good and a problem. So it's a big issue. Okay, you're going to advance it. All right. On the handout I gave you, down at the bottom, this diagram, this flow sheet, if you wish, overlapping syndromes. There's so many things that make this thing difficult. So abdominal pain is usually a major presenting symptom, whether it's functional or organic. You've got to figure out which is it. Because as you try to treat them, if you use narcotics, it's going to make your nausea worse and your motility worse. Okay? So as we look at this abdominal pain, you see a lot of overlap, and you got nausea, early satiety, vomiting. Those things kind of drive you to organic reasons to think about gastroparesis. Weight loss. I had a gentleman come to my office about a few weeks ago. Already seen 2 other gastroenterologists, been to Mayo's, had 8 days there, workup. Tremendous weight loss, so something like 18 pounds in about 4 or 5 months. A lot of nausea, just debilitated because of his pain and nausea. Trip to Mayo's, did not much to him. The the GI guys didn't know what was wrong. And I hate to say that it didn't take me very long to figure this thing out, because I understand gastroparesis. It's abdominal pain, it's nausea. We got to take care of those symptoms. So we're going to talk about medicine to how to take care of this so that it functions. So we got to understand this overlap diagram well to get us to the point that either got bad constipation, diarrhea, some kind of motor problem of the bowel, but mainly nausea and pain in the epigastric area. Okay? All right. So severe nausea and vomiting can be so debilitating, like this gentleman, and it took me about a week to get him in order. 1 week. He had been suffering for almost over a year. And he had vomited so much. He'd been to the ER many times, getting electrolytes replenished. He was dehydrated, malnourished, losing weight. He wasn't a diabetic, but often we see these people, their diabetes is poorly controlled because they've had poor glycemic control. They're spilling over, they're slow to spill their gastric contents. There's an overshoot of insulin, and they get hypoglycemic events quite regularly. So it's a real issue for people who have diabetes, who have gastroparesis. All right, next. All right, prevalence. We don't really know how many people have this, but we're talking about millions. I mean, people, this is something you've got to understand this. And time again in the office, I see people who have, the giveaway is diabetes. You got a pretty good chance they're going to have gastroparesis if they're diabetic. Type 1, about 20-40%, and long-standing. So they had diabetes 10 years. The problem with gastroparesis and diabetes is slow in onset, and you don't pick it up. So the others we're going to talk about in a minute that begin suddenly, they can tell you, I have something that began at this date and this time. Diabetics don't really remember when it began. All right, so a couple of little slides of some studies that sort of tell the story about how the etiologies then are dispersed in looking at people with gastroparesis. Idiopathic is the biggest category. Well, that means that we don't know what the heck it is. Well, it really is the biggest category. And then idiopathic, diabetic, and post-surgical. Those three make up 90% of gastroparesis. Wow. So if you just kind of understand those three things, that's going to help you an awful lot. There's other things like Parkinson and vascular disease, ischemic disease, that can cause problems with the stomach emptying due to inadequate supply of blood. All right, next. All right. So, delayed gastric emptying is the definition. The most common cause of gastroparesis. And again, it can be functional or organic. You can keep that in your mind. Symptoms can fluctuate. You have episodes that interstitials can have sometimes to go away and come back. But many of these people who have organic disease, usually they're fixed. Nausea and pain is just severe. And often these are people who have idiopathic viral origin are usually young or middle-aged women. I don't know why. Okay, next. All right. So the symptoms may resolve after several months or years. I mean, this can go away. Yes. If it's viral, has a viral trigger, right. Gastroenteritis. I remember when it started, doctor. My nausea began right after I was sick. I had gastroenteritis so bad, and then I was just nauseated, and I've been nauseated ever since. And I have this pain. It won't go away. So often a viral trigger will be the beginning, and it has a tendency to kind of burn itself out. So if you get to understand these people, and you think, well, maybe they have a viral origin that precipitated it, they're going to have a fairly good prognosis. A year and a half. It can go away, and we get credit for that. But we just support them diagnosis. So, okay. Another that same study showing that those idiopathic type of gastroparesis, a good many of them had viral and could say I know when it started. It could begin after that. Severe abdominal pain, almost always that, and nausea are the two hallmarks of organic gastroparesis. A fair number of people have reflux. If the stomach is slow to empty and it builds up here, you have a greater chance for it to reflux. So many of these have reflux secondary to the problem. Okay? In this study, that fair had a depression. But look at this. 8% were after a gallbladder surgery. Whoa, did something happen in surgery? We're going to talk about that. So well-meaning as surgeons can be, sometimes it's tough. As you try to separate and dissect away, you may injure a branch of the vagal nerve. Next slide. So, it's a recognized complication of diabetes, okay, whether it's 1 or 2. 40-50% of people with type 1 diabetes will get it. Usually it's the longer duration, 8-10 years. 34% of type 2 get it. Pretty common. Again, the problem, it comes slow. It didn't come suddenly, and so that's why you guys miss it so often. Well, I'm just so nauseated and I don't feel good, and you're having trouble with your diet. Yeah, I can't get my diabetes controlled. Think about gastroparesis. Okay, next. All right. So, something may have happened to affect the gastric motility, something that happened to the vagus nerve, and the diabetic gastroparesis is a little like peripheral neuropathy. It's a neurological problem. It affects the nerve. It takes a while for it to happen. So often we get problems and tips to say, you've got diabetic, poor control, your glucose is fluctuating too much, something isn't right, you're not doing well on your medicines, you may have gastroparesis. So we're going to talk about diet here in a minute. And that's what gets to be a problem for a diabetic because they have a limited diet. They have to make sure they have to have certain kind of foods. They can't have a lot of fats or sugars. And these often will create problems as they get spilled into the duodenum slowly. And they get a delayed effect. Insulin is used, and then it's really a difficult thing trying to control the hypoglycemia usually with diabetes. Next slide. Okay, surgery. Surgical causes. All right, well, fundoplication, and we have a fair number of surgeons still in Tulsa that like to wrap the hiatal hernia around and give them fundoplication. Hard not to injure a vagal branch. Numbers are close to 15% post-fundoplication, and that's permanent. Few of them will get better, but it's usually a permanent problem. So gastroparesis is going to occur as a complication, variety of anything that has to do with the vagal nerve. Post-vagotomy, Bill Roth 1, Bill Roth 2. Post-fundoplication is the more common one today. We don't do many Bill Roth as 1 or 2 surgeries. Bariatric surgery, that's pretty common. See? It's kind of hard not to injure the vagal branch, whether it be a Roux-en-Y or not, and even open the chest. So lung or heart transplantation, extensive surgeries can injure a branch of the vagal nerve, causing gastroparesis. All right. So there's all kinds of conditions that metabolic that will create some delayed gastric empty. And first thing we want to do is we want to rule out mechanical obstruction. Otherwise, we're going to have a surgeon, he's going to fix it, and he's going to take care of it. So sometimes a delayed effect of emptying may be due to obstruction. So endoscopy comes into play pretty early. The symptoms are usually non-specific and may mimic structural disorders like peptic ulcer disease. Okay. It could be gastric or small bowel obstruction, gastric cancer, or pancreabiliary disorders. So there's a whole bunch of overlap, okay, of gastroparesis between organic and functional dyspepsia. And on your handout, that overlap map is confusing, but listen, this is a tough subject, and you need to work through this thing. Say, okay, I've got all these organic symptoms. I'm pretty sure it's an organic cause that gives them slow emptying of their stomach. Next slide. All right. So we do endoscopy or x-ray. And what do we see that would help suggest you have gastroparesis? Endoscopy often sees stuff. Stuff meaning it could be a bezoar. And some of you have been in my service, I've called them a bezoar. A bezoar is usually something that doesn't do anything. It lays there, it doesn't work. It just, kind of a bezoar is the worst insult you could be called. So gastric material stays, food stays in there. It can be organized or unorganized. Or you may see, again, if they've been NPO, they may have nothing but just a stomach full of bile. What's bile doing back in the stomach? So I had to come back from the small intestine and come backwards. So there must be something wrong with the motility because it's supposed to go out and it's supposed to be down in the duodenum. So seeing bile and big pool in the stomach is a hint. And then the next hint on endoscopy, where's those 3 per minute contractions that we talked about from the pacemaker? So it just lays there. It doesn't do anything. You may see 1 contraction. So, we're in there several minutes. You got to get an idea, like, we have an impairment of motility. So gastric emptying then can be impaired, and you get gastroparesis. So x-ray endoscopy is very, very important to get started out with. All right, next. All right, so gastric emptying studies. All right, we're going to talk about that. Gastric contractile activity, that can be through endoscopy. There are some other modes that can help that. There's a EGG. We don't do that very often. And then we have a new thing that helps us know when the stomach is empty. It's much like the gastric emptying test. It's called a SMART pill. All right, we're going to talk about that in a minute. Next slide. Okay, so as you do the H&P, you got all those questions. You say, okay, any surgery? What has happened? Are you diabetic? You go through those things. What structural tests are you doing? Sometimes just putting your hand on their abdomen, you get a succussion splash. They're full of fluid. Okay, might help you. And some of you don't remember some of your physical diagnosis, but Carnet's sign. So you push on the abdomen and they tense their abdomen. It makes their pain worse. They're stretching their abdominal muscles over already distended stomach. So you can do some direct, some indirect, some neuromuscular test, and we're going to talk about gastric emptying study, which is the gold standard right now. All right, so you've done the history, helping take a study. Are they taking narcotics? Did someone give them some pain medicine? Some codeine. You helped them out. And is that making things worse, or is that the sole cause of it? Often they come in, they got 2 or 3 narcotics they're taking. You're like, wow. So medications are big cause of gastroparesis. And maybe just by removing that out of their regimen of medicines makes things better. So do they have a metabolic state? Do they have a stroke issue? Do they have some kind of problem? Do they have a possible obstruction? And so maybe you want to do a CT scan and if you do an endoscopy and you can get far enough down, maybe it helps you then decide. So it can be a rule-out diagnosis problem. Okay, so gastroparesis can be established, and you measure it by doing a nuclear medicine study, well-tolerated egg meal, easy to perform, easy to interpret, pretty standardized in the country. You don't have much radiation exposure, and you can measure to see it's completely eliminated. All right, next slide, I think. All right, yeah. This talks about low-fat meal, gastric emptying. So we have an isotope in a egg meal. They eat that, and we measure how slow or how fast that then leaves the stomach. Anywhere between, on your handout, talked about 37 to 90%. Anything better than that is okay. The time that's the most important is the 4th hour. Okay, if it's longer than 10 minutes, we got a problem. Okay, So if 10% of the food is still in the stomach, 40% or more, we have a problem with gastroparesis. We have some kind of emptying issue. Now, we always make sure, take them off all their medication. Don't give them any anticholinergics. And boy, those are used for all kinds of functional problems. Don't do anything to paralyze their stomach and help the emptying issue. So we want to make sure that we treat everything that we need to treat, correct the fluids. If they have a diabetic, try to correct that. Check all the things possible to help reduce the symptoms. One of the next slide. Okay. So, of all the things, if this is a motility problem, we need to give them a pro-motility agent, a prokinetic. All right. So, you got a few choices, not a lot. Okay. So, this guy's been around as long as Joe Wolf. Okay. It's old. It was around when I got in medical school. Still here. It would never pass the FDA. It has so many side effects. Okay, and so you can get irritable, get tardive dyskinesia, which sometimes can be permanent. You can give them a drug that can, you can have Parkinson-like tremors. So it's kind of a nasty drug. I call it a nasty drug because I don't know any drug that gives you so many side effects. We always have to apologize to the patient and say, I'm going to give you something that might cause some problems. And if we give it to you and it does it, I want to know within the first week, if you have any problems, stop it, please. You have to change your personality. And so metoclopramide, Reglan. Okay? If it works, it's great. Not expensive, around a long time, and it's a pretty good agent. Erythromycin, an antibiotic, has a Modelin effect, and it can help stimulate the stomach. But it seems to burn out in a matter of a few weeks. And it loses its effect pretty quickly. Cisapride was a great drug. They took it off the market because and I mentioned in the handout, it caused some EKG abnormalities and enough that the FDA is kind of paranoid. They don't want any problems. So we don't have a lot to choose from. Okay? This is the only one that's really available. This doesn't work very long. This one's gone. And what about this guy? Not currently available in the U.S. That's wrong. Compounding pharmacies will make this drug for you. And we have about 6 or so in Tulsa, several in Tahlequah. Their compounding pharmacies in this state are well and thriving. About 27 states have laws that allow compounding pharmacies to make medicines that you cannot normally get. So, domperidone, not domperignon, the French wine, domperidone is the drug, often called Motilium, made by Janssen Pharmaceuticals. And if you can't get it at the pharmacy, I give them a handout and say, here, get on the net, you can order it. It'll cost you about 10 cents a tablet. Whoa, yeah, 900 of them, $95. So, not very expensive. And you get it in the bottle from Janssen Pharmaceuticals, and the place you get it from, Australia. It takes about 14 days to get there. So, the side effects of both prokinetics and antiemetics are somewhat similar. They have some problems. Next one. All right. So if you don't do but a couple things for the patient, they got nausea and pain. Take care of that. Don't make it worse. Don't give them narcotics. Okay? So Phenergan's okay. Phenergan's fine. It's not a bad drug. It can help. You can use it gel, use tablet. You can take it up the rear end. Suppository. It works. Okay? So all those are fine. My favorite anti-nausea medicine, because remember, this is a chronic problem. Slap a patch on. Okay? So got a couple of them we like. I wrote those down for you. And you can put a patch on. Lasts for 3 days. Sancuso lasts up to 5 to 7 days. Controls the nausea. And sometimes that's the most debilitating part of this disorder. Okay. So, but again, all those drugs, okay, can cause sedation and even some potential extrapyramidal problems. Okay. All right. So prokinetic drugs are the drugs of choice worldwide for GI motility disorders like gastroparesis. Reglan, up to a third of them have side effects. So you got a chance, a third of your patients can't take it. Okay. Erythromycin, it makes me nauseated. I can't take erythromycin. So it can cause symptoms that may mimic those of gastroparesis. If it works, it's not a bad drug. Pretty simple. Just can't take it for a long period of time. Cystic surprise gone. The drug of choice for this prokinetic is domperidone. Okay. So I have to give them a sheet. Say, here, get on the net. If I write a script, it's to the apothecary shop or somewhere close where they can get it for a week or two. And then I said, if it works for you, good. Get your script filled and get on the net, and then get your large volume. Do other things that can help the distress of the stomach. These are pretty dramatic. Putting a G-tube in. Wow. So, peg tube. Don't like to do that. I have a couple of them that have gastroparesis. They decompress themselves by opening their tube, letting things off. They're able to eat, but they get out of control frequently, and they open up their tube and decompress themselves. So sometimes feeding through the tube can be okay, but often their oral route is still all right, and they can feed themselves in a suitable manner. Next slide. All right. Again, showing the peg tube and how that lays in the stomach. So you can have a tube like this laying in the stomach, feeding the stomach, or just for decompression. So most of the time we use tubes, it's just for decompression. We don't usually use feeding. They have gastroparesis. Okay. The tube itself can lead to problems. You put the insert through an opening in the abdomen. So feeding the tube, using a feeding tube can be better. There may be better ways to approach the problem than putting a tube in. Enteral feedings often don't alleviate the symptoms. So people think that may be it. Now, they still can eat. Whether they feed this way or this way, they still get gastroparesis. Next slide. All right. People who are refractory, can't take drugs ever. Several years ago, almost a decade now, Dr. Foster and I went to Minnesota, and we were going to be schooled and taught, and he was going to be schooled surgical-wise in how to put an implant in the stomach to create and alleviate gastric motility, take care of gastroparesis. So there's some surgical things you can do. You can, if they have an outlet obstruction, pyloric scarring from ulcers, you can do surgery on that. You can do a pyloroplasty. You can do it endoscopically, or you can do it surgically. You can inject Botox. I always say, whatever's left of the Botox, I want to use on my face. But you can use Botox at the pylorus to relax the muscles around the pylorus, and you can help the emptying problem if they have pyloric stenosis. Gastric bypass often comes in play. That they have a Roux-en-Y diversion, but having the bypass itself doesn't handle the problem. But often, in the process of doing the surgery, one of their problems is they have nausea and discomfort as a result of injuring a vagal branch. Next. All right. So TPN can be used. It's an alternative. So you can feed someone and not even use their stomach. Sometimes you have to do that if they've lost a lot of weight. And so the cost of TPN is mega. Okay. So 200,000 is probably underestimation a year. So it's an expensive process. All right, next one. All right. So refractory patients then can have a neurostimulator, Entherra. Okay, a device that is implanted in the skin. Electrodes are placed through the gastric wall, down this antrum, 10 centimeters from the pylorus, and it can stop nausea and increase gastric contraction. Not bad. We really rev it up. Usually crank it up about 4 times what you normally get. So about 12 contractions a minute with a neurostimulator. It can be wonderful, but it also can fail. It's not as wonderful as we once thought it was. We OSU, are the only institution in Oklahoma that do this. There was one down in Oklahoma City, and they've stopped. We don't have many calls for this. Best used for insulin-dependent diabetics. They seem to respond better. So not a bad tool for Entherra Therapy in some patients. People want to jump at it. I mean, have surgery and fix this thing? Okay. That's if you failed everything. How often does medical therapy work? About 90% plus. It's pretty successful. So we don't really send many to them. When we do, Foster's got several of mine. They have chronically getting readjusted and their stimulator reevaluated to make sure they're getting adequate stimulation. Sometimes you have to replace the electrodes, make sure that things are going okay. All right, and this is kind of the end of this. So this device then can be placed in the skin. These electrodes then are under the gastric, there's 3 of them, under the gastric mucosa, and it can stimulate, and they fire off light made by the same people, Medtronics, to make the cardiac stuff. Medtronics makes this Entherra for the neurostimulation. It was called a gastric pacemaker, and that's probably not a good name. So it's a neurostimulator of the stomach. Okay. So it was approved in 2000, and it's hung around. It's still limitedly used, and it can be very effective if you have total medical therapy failure. Okay. Should turn the lights on there. Yeah, that's okay. Joe, you got any questions? I woke you up twice. So remember, pneumatic, NEV, BP, nausea, early satiety, vomiting can be so bad, bloating, pain and nausea, Be careful about the pain medicine you use. It can make things worse. And then worry about Reglan. Durant. How are you guys in Durant? Okay.
We're doing good.
All right. We thank you guys. Appreciate it.
Thanks for waking me up.
Oh, thanks for the joke.